Alaikum. Welcome again to the medical student whom join us in this series of lectures of cardiovascular disease. Really, this is the last lecture in the cardiac arrhythmia, and it is last lecture too in the cardiovascular disease for first and second semesters. We will find in the some ECG record and a record did not look like to any types of arrhythmia. What's called artifacts occur when the something causes disruption in a monitoring and ECG recording. Some common causes of artifacts is the muscle tremor and respiratory artifact, wandering baseline, loss of loose electrode and broken leads wire and so on. So look like that. It is not like any types of arrhythmia. This is an artifact. This normal sinus rhythm, and this is not look like any types of arrhythmia. So this is what called ECG artifacts. And this is the ventricular fibrillation, as we say. Is there is no QRS complex, no P wave, even no electrical baseline. As we said, it is serious. The patient hemodynamically unstable, hypotension, shock, pulseless, and even unconscious cyanosis. So this is the ventricular fibrillation, quite different from the previous artifact. This is monomorphic VT. It's also we can differentiate from previous lecture. This is what called run of the premature ventricular ectopic less than 30 seconds, and this is what called types of VT, but it is non-sustained VT. This is a polymorphic VT. It's different from the artifact what we see, and this is what called torsade de poids. Is the up and going a point oscillating point around the isoelectric line. So our lecture today is the what cause of palpitation. As we know, the arrhythmia can be presented without symptoms and asymptomatic could be the second most common palpitation. SVT with the preserved cardiac output cause palpitation. Ventricular tachycardia with the preserved cardiac output. Atrial or ventricular premature beats. The patient can and feeling this palpitation. There may be no rhythm abnormalities during perceived palpitations. Other cause, example anemia, hyperthyroidism, thyrotoxicosis, and this is what's called sick sinus syndrome. This tachy and bradyarrhythmias, in which after the pause there is no escape rhythm. I mean there is no junctional or ventricular escape rhythm. Conduction problem with this is a rare sick sinus syndrome. Conduction problem with no junctional escape during sinus pause. And this is the sinus pause not, as we said previously, is the full compensatory pause, is the prolonged. And diagnosed with ECG or Holter monitoring. In conclusions, inconclusive, not if, inconclusive, need electrophysiological testing. Sometimes do EB study. And if asymptomatic, leave alone. If symptomatic, need pacemakers, the patient symptomatic. While sinus pause or sinus arrest, not sick sinus syndrome, is the rate normal. Those that are present are normal, QRS complex normal, conduction normal, rhythm, the basic rhythm is regular. The length of pause is not a multiple of sinus interval, as it's not complete compensatory pause. This may occur in individual with healthy heart, sinus pause or arrest. It may also occur with increased vagal tone, myocarditis, MI, digitalis toxicity. If the pulse is a prolonged, escape beat may occur, not like the sick sinus syndrome. treatment of this dysrhythmia depends on underlying cause. If the cause is due to the increased vagal tone and the patient is symptomatic, atropine may be indicated and beneficial. So it is sinus, sinus, sinus. Come to the sinus pause. Sometimes we see the junctional rhythm, escape rhythm. And this is not doubled at the sinus interval, RR interval, what's called sinus pause or sinus arrest. Come to the tachyarrhythmia. We study a supraventricular arrhythmia. We take example, premature atrial contraction, atrial fibrillation, atrial flutter, and ventricular tachycardia is a supraventricular, ventricular tachycardia is tachyarrhythmia, monomorphic, polymorphic, torsade de poids, and ventricular fibrillation. What remaining is supraventricular arrhythmia. We not discuss this subject. So we paroxysmal supraventricular tachycardia or supraventricular tachycardia, a single ectopic like that in a row, single ectopic focus fire near the AV nodes, which often conduct normally to the ventricle, usually initiated by premature atrial contractions. The rhythm is always regular, what called deadly regular, equidistant there and regular. Prolonged runs of paroxysmal SVT may result in the atrial fibrillation or atrial flutter, may be terminated by spontaneously or carotid massage. Treatment: carotid massage, adenosine rapid IV, calcium channel blocker like verapamil. If it's resistant to the drugs and drug dependent, prolonged young patient ablation, radiofrequency ablation, adenosine preferred in hypotension, and previous IV blockers, and the previous IV blocker the patient take, or oral IV or oral beta blockers. But calcium channel blocker is not given to the patient previously on the beta blocker because it causes standstill. So this is sinus, 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 and this is a premature atrial contraction initiated this rhythm, which is maybe terminated spontaneously or terminated by carotid massage or given adenosine or verapamil. This in your textbook in Davidson, supraventricular tachycardia. The rate is the 180 per minute. QRS complex are normal. P wave, if it's not seen, if it's seen abnormal, sometimes not seen. This not seen P wave in the SVT. It's regular, what? Deadly regular. So it's a re-entrant arrhythmia at AV node that is spontaneously in onset and sometimes spontaneously in the stop or its end spontaneously. May have wakefulness, hypotension, and or polyuria after the attacks. Well, the mechanism of polyuria change in the plasma level of atrial natriuretic peptide, increase of natriuretic peptides. Neuro QRS complex. So QRS complex is neuro. This is mean that the impulse around the AV node or above the AV node. First line is vagal maneuvers. And second line is adenosine or verapamil. Please don't give verapamil or calcium channel blocker in patient taking beta blocker on a chronic basis because it may cause a standstill. Give adenosine if the patients have not bronchial asthma. For chronic SVT class 1, a class 1C or amiodarone or sotalol beta blocker work well. Ablation will cure it too, and a good result. But we usually do this only in young patients. This is the SVT, supraventricular tachycardia. This is abnormal P wave. This P wave there, but it's abnormal P wave. So management of SVT in a short treatment is not always necessary. However, An attack may be terminated by carotid sinus pressure or massage or other maneuver that increase vagal tone like Valsalva maneuver. Intravenous adenosine or verapamil as isoptin will restore sinus rhythm in most cases. So in a short management, suitable alternative drug include beta blocker, fluokinamide, digoxin can use if it's not wide, narrow QRS complex. So in emergency, when there is a severe hemodynamic compromise, the tachycardia should be terminated by DC cardioversions. If attacks are frequent or otherwise disabling, prophylactic oral therapy with beta blocker, verapamil, disopyramide, digoxin may be indicated. Catheter ablation, radiofrequency ablation in the electrophysiological study offer a very high chance of complete cure and is usually preferable to long-term drug treatment. So management in a general of the supraventricular tachycardia, treatment underlying cause, DC cardioversion if hemodynamically unstable, drug therapy like adenosine, verapamil, maintenance therapy if the patient young and that they not responding to the drugs or need prolonged drug treatment, radiofrequency ablation. So this is that the SVT, narrow complex tachycardia, rate about 150. There is no P wave, is irregular. If we see it's a deadly regular. And there are, look to the pseudo R wave in V1, V2. Look to the V wave, pseudo R wave, pseudo not R wave. And the no P wave, rate 150 there, and the regular and no P wave, and the pseudo R wave in V1 or the V2. This is what called SVT, supraventricular tachycardia. This is another example, not a complex tachycardia. The rate is about 220 beats, no visible P wave. It's quite irregular. If come to that the PV1 there is and V2 there is pseudo R wave, initial R wave, and this supple notching in the R wave. We will find ST depression, which is common finding there, and doesn't necessarily indicate myocard. It may be ischemia, but if you return to the sinus rhythm, provide change in the by ever resolved spontaneously or terminated by adenosine or verapamil calcium channel blocker, this ST segment disappear. If it persists, there is underlying ischemia. Come again to that the next abnormal rhythm is the Wolf Parkinson-White syndrome. Is the ventricle receive partial signal normally from the normal and the partially through accessory pathway. There is accessory pathway. Symptomatic tachycardia, usually there is symptoms. Short PR interval. As you know, the PR interval is the 0, 1.3 small to 5. This is less than 3 small square. With short PR syndrome, it's one of its is Wolf Parkinson-White syndrome. Delta wave, and we will see what's delta wave. And prolonged QRS complex more than 3 small square. Electrophysiological testing help to identify the re-entry pathway and accessory pathway and location of accessory pathway. So this is what I mean by accessory. This is a normal nodal IV node and down partially and partially from re-entry anti-clockwise through this accessory pathway was called bundle of Kent. You could be in the right, could be in the left, it depends. But no need to know these two types, just to know there is an accessory pathway and passes in this re-entry re-entry circuit. During that, this is the atrioventricular re-entry tachycardia, like what called SVT. So ECG feature of Wolff-Parkinson-White syndrome is a sinus rhythm, but PR interval short. Delta wave is the proximal part of QS complex is pulling, and the slurred rise of initial portion of QRS complex. That's why shortening PR interval at that time prolong the QRS complex. Is a prolonged QRS complex. ST segment and T wave discordant. It means discordance with the if ST segment and T wave and QRS complex. If it's up QRS complex, this is down. If it is down, this is up. That's to say in opposite direction, in opposite polarities to the major component of a QRS complex. Look to that, this normal ECG. Impulse coming from SA node to the atria down to the ventricle with the P wave, QRS complex, and the ST-T wave, and ST and T wave. This is the accessory pathway. It's coming there and some during accessory pathway. This is what called delta wave. It's the pulling of proximal part of a QRS complex up. What called, that's why PR is shortened, QRS complex become widened. And what called discordance of ST-T wave, the main part of a QRS complex is up, this is down. Delta wave, short PR interval in a sinus rhythm, what's called six sinus syndrome. So, Wolff-Parkinson-White syndrome. Because of Wolff-Parkinson has both normal conduction through the AV nodes and accessory pathway conduction that bypass the AV node, atrial fibrillation can happen via accessory pathway. It's common to find Wolff-Parkinson-White syndrome with accessory and with atrial fibrillation. Inhibition of AV nodes will end up in a worsening of atrial fibrillation because we suppress normal, so atrial fibrillation through this, it will be worsened because none of the signal are slowed down by the AV node before initiating the ventricle. Don't use any medication that will slow AV node conduction. That's to say the digoxin, beta blocker, adenosine, calcium channel blocker in Wolff-Parkinson-White syndrome, especially if the wide QRS complex. The best choice is the procainamide class 1, as it is slow the accessory pathway. If the patient becomes hypotension, cardioversion DC is necessary. So look to this ECG, to the V1, look to the slurred QRS delta wave, short PR interval. This is slurred with this delta wave and sinus rhythm. If we look, sinus rhythm, delta wave, short PR interval, and the ST-T wave in the opposite direction. If at the same direction, this means there is ischemia or myocardial infarction. So this is another example of Wolff-Parkinson-White syndrome, delta wave, short PR interval, wide QRS complex, and this is the dominant R wave, this is the opposite polarity of ST-T wave. This is another example of the Wolff-Parkinson-White syndrome. This is two, and the Wolff-Parkinson-White syndrome. This is the delta wave, and this is the PR interval is short. Wolff-Parkinson-White syndrome. Now come to the last subject is interventricular conduction block. What I mean by that is that we have a right and left bundle branch block, and that the right bundle branch block and left bundle branch block, this could be complete if the QRS complex widening. If a normal, it's incomplete. Non-specific interventricular conduction delay there is. We take first degree, second degree, third degree in a block. Arrhythmias, now we complete in the right, left. There is left anterior fascicle hemiblock and left posterior. It's not our subject today, only right and left. This is the AV node bundle of his. This is the right bundle branch block. and this is the left two branch, left anterior, left posterior, maybe complete left, maybe left anterior, left posterior, maybe 3 vesicles, I mean left anterior, left to right, or a first degree heart block, left and anterior to triple and trifasicular block. Anyhow, let us to that the blockage in the right bundle branch block there in the red, in the right bundle branch block in the red. Left ventricle excited by this purple excitation. Then the impulse after completes not coming by the right, it's a block, it's coming through the ventricle. That's why QRS complex, it will be bizarre, wide through this blue arrow to stimulate and to depolarize the right ventricle. This block complete in the right bundle branch block. So criteria of right bundle, QRS complex duration more than 220 milliseconds, or 0.12 milliseconds, more than 3 small squares. Why? Because it is the activation or depolarization of right ventricle come through left ventricle, not through the bundle. There is some obstruction in the bundle. Wide S wave in lead 1 AVL V5 V6 in left side. S wave deep. See R small S R prime pattern, or the notch R wave in V1. M shape we will find it. Appropriate discordance if we find the ST segment and T wave always go in opposite direction and of the main vector of a QRS complex. So look to that. This is wide S wave in lead 1, a deep and wide S wave in lead 1. And this is what called M shape in the V1, V2. This is initial R wave, then S wave, small QR, R wave, prime. Look at the rapid ear. It's a rapid ear phenomena. Or M shape, wide QRS complex and discordance of the STT wave, opposite polarity of dominant R wave. So this is if we find deep S in lead 1, AVL, V5, V6 with the M shape like that, or rapid ear, this is a right bundle branch block. If this is prolonged like that, this is a complete. If it's narrow, less than 3 small square, it's incomplete right bundle branch block. Causes may be normal variant of adult. The prevalence increase with age. Coronary artery disease like acute myocardial infarction of occlusion of proximal left anterior descending, or LID. Chronic cor pulmonale, acute pulmonary embolism, congenital heart disease, as we discuss in atrial septal defect, cushion defect, and Brugada syndrome. Clinical significance, if there is a concomitant, it means T wave is coming the same direction of the main R wave. It means there is some pathology underlying. And if concordant T wave with the bundle branch block may suggest ischemia or infarction. This is in the left bundle branch block too. Right bundle branch block in a setting of acute MI worsen the prognosis. One of worse prognosis indicate proximal left anterior descending artery occlusion, infarction of interventricular septum. Both left bundle branch block and right bundle branch signify large area of infarction, hence associated with high risk and poor prognosis. Come to the second left bundle branch block. Is really almost always pathological. It's not coming normal. Activation of left ventricle is delayed and conducted later than the right ventricle. As we said, to start with the right and then to the left. That's why QRS complex is wide and bizarre shape. And we see the reverse, M shape in the V5, V6, lead 1 AVL, and deep S wave in the V1, V2. So duration is like broad R wave in lead 1, AVL, V5, and sometimes M shape. Prominent QS wave, deep S wave in V1 or V2. absence of a Q wave in V1 and V6. Widespread secondary abnormality should be also present. I mean in the STT wave. Lead 1 AVL usually display downsloping of ST depression, leading to into an inverted T wave, discordance. Lead V1 usually display deep S, as we say, with the upsloping ST elevation in opposite direction of ST. And of S wave, leading into the upright and prominent T wave. So look to that, there is no Q wave, wide QRS complex, and the opposite direction lead 1 AVL. Up we come to the V5, V6, and this is what called deep S wave in V1, V2, and the STT wave in opposite direction like an MI. That is why in acute myocardial infarction with left bundle branch block, it's sometimes difficult to give a diagnosis if it is a new one. So broad R wave in D. This is wide, sometimes M shape. Even sometimes M shape we find that the V5, V6. And prominent S wave in V1, and absence of a Q wave in lead 1 and V6. Down sloping in this and up sloping in V1, V2. This is the left bundle. If it's wide, so it is complete. If it's narrow, incomplete. Causes almost always pathological. Coronary artery disease, acute MI, it means acute wall myocardial infarction, new onset left bundle branch block. Dilated cardiomyopathy, aortic stenosis, long-standing hypertension can cause. Very significant to find left bundle branch block. New onset left bundle branch block is indication of a thrombolytic therapy in a setting of the myocardial infarction. Sometimes difficult to diagnose. Go to the biomarkers or other investigation like isotope to see if the ischemia is recent or old. Left bundle branch in the setting of acute MI really is a worse prognosis, a big infarction. Presence of left bundle branch block cannot be used to diagnose left ventricular hypertrophy or infarction because left bundle chronic, I mean not recent one, because left bundle itself result in the wide QRS complex and upward STT wave in the V1, V2 segment elevation consistent with injury or like that consistent of injury. This is our homework. Please do it and report and send it back. 65 years old man come to emergency room with the retrosternal crushing chest pain of few hours duration and suddenly collapse while the nurse do ECG on a machine, give this strip rhythm. So do a report of this rhythm and what immediate treatment for this. See you soon.